Mr. Aguilar is a 26-year-old Hispanic male who is being seen today for medication management for ADHD, primarily inattentive, and insomnia. He was first diagnosed with ADHD at age 8 due to not being able to sit still and consistently disrupting the classroom. He was prescribed Ritalin at age 8 and remained on it throughout elementary school. In middle school and high school, he was on Concerta, but it eventually stopped working for him. In college, he was started on Adderall XR 10 milligrams PO daily, and this has been the most helpful medication for him to manage symptoms as an adult. He was diagnosed with insomnia in college due to work and academic demands that disrupted his ability to fall asleep. Patient reports after he graduated and started working, the insomnia persisted due to worrying at night that he missed something important at work. He is transferring care from his previous psychiatrist, Dr. Sam Walden, who no longer accepts his insurance. Patient states that he would like to continue his current medications, which are Adderall XR 20 milligrams QAM and Trazodone 100 milligrams PO QHS for insomnia. He states that all medications are working well to manage his symptoms. His symptoms include poor sleep quality and quantity, nighttime racing thoughts, poor focus, poor attention, easy distractibility, disorganization, forgetfulness, difficulty multitasking, and overthinking. Mr. Aguilar works full-time, managing supervising a large construction company, and reports that when he does not take medication for ADHD, he has a very difficult time staying on task when he's at work, and he tends to make a lot of mistakes. In addition to his past medications, Ritalin and Concerta, he was previously prescribed Wellbutrin XL 300 milligrams daily for his ADHD symptoms. This did not work for him. He was also prescribed Ambien for insomnia, which caused hypersomnia and next-day sedation. Patient denies past medical or surgical history and states he is otherwise healthy. Family psychiatric history includes his dad, who also has ADHD, but he does not take medication. His mom has MDD and takes Prozac with effective relief. There is no personal or family history of alcohol use or substance use disorders. The patient denies history of abuse or trauma growing up. He denies SIHI. He denies past history of inpatient psychiatric admissions. When considering his social history, the patient has never smoked cigarettes and drinks socially and sparingly on the weekends with friends. He denies illicit drug use. He practices jiu-jitsu 3 times a week at a martial arts studio. He is single, never married, no children. He identifies as cisgender male and dates women only. He lives alone in an apartment and has a cat. His parents and immediate family live nearby and they get together often. The patient presented today well-groomed, friendly, and attentive. He maintained appropriate eye contact. Affect was congruent to mood. Thought processes were logical and linear. Insight and judgment were appropriate. The DSM diagnoses for this patient include F300 ADHD, primarily inattentive, and G4700 insomnia unspecified. He left the visit with a prescription for Adderall XR 20 milligrams PO daily, quantity 30, refill 0, as well as Trazodone 100 milligrams PO QHS, quantity 100, refills 1. The patient agreed that once a month follow-up is appropriate and that his Adderall can only be filled every 30 days and no early refills will be authorized. I provided the contact information for the patient in case he needs an appointment sooner. I encourage the patient to take breaks from Adderall on the weekend to avoid having to titrate the dose up on his Adderall. I asked if he would like to start counseling with one of the therapists on staff, and he declined a need for that. My preceptor was the clinician who diagnosed and prescribed for this patient. If I was leading the visit, there are a few things I would have addressed that my preceptor did not. First, I would get a drug screen prior to prescribing the stimulant to assure no other substances came up positive. I would also tell the patient that I collect random drug screens twice a year to assure he is taking the medication and not mixing it with other substances. I would have also run a cures report to assure he was not going to other offices seeking controlled medications. I would also get an EKG prior to starting Adderall. My preceptor did not go in depth as to why he is struggling to fall asleep. I would have started by reviewing general sleep hygiene strategies with the patient. I would have asked about caffeine intake, supplement use, and electronic device use at night, especially if he is prone to scrolling on his phone to try and fall asleep. I would also ask if he plays video games at night to wind down from his day at work. I would also ask if he has ever forgotten to take his Adderall in the morning and instead taken it midday or early afternoon, which could be keeping him awake.